Good afternoon, everyone, and welcome to our annual World AIDS Day digital conversation that centers the voices of those living with HIV and AIDS. I am Pastor Cynthia Turner Wood of the Dayspring Community Church in Lanham, Maryland, and I'll be serving as your moderator today. I want to welcome you on behalf of Woman Preach to tonight's digital conversation, and thank you so much for participating in the conversation. This work that is being done around this issue of HIV and AIDS is, as you know, a critically important work, especially for our people. And we are excited that you are here and excited to have the panel that is with us. I want to let you know that this conversation is the fifth in our annual board curated series, and it is one that we take to heart. I especially want to welcome our esteemed panel this evening, and on behalf of our Woman Preach president, our leader, our founder, Dr. Valerie Bridgman, and all of the Woman Preach board members, and especially for our board chair, Reverend Dion Boissier, who did so much to make this evening possible. I want to let you know that Reverend Dion is not going to be able to be with us tonight. She sincerely regrets it. And also want to let you know that it is because her father has passed on this very day, but she did do a great deal of work to make this event happen. And so if we could just take a moment of silence to remember her father and to uphold her in this moment. Thank you. As we move forward, I want to bring the panel in and give us an introduction. Each of them will introduce themselves and talk to us about the different ways that they are working to keep the issue of HIV and AIDS in front and center in today's health discussions, so that we don't forget how much it still has a foothold in our communities, both locally, nationally, and internationally. And as they bring their introductions forward, I want to keep in mind, if they could speak to the issue that even on yesterday, I believe President Biden in his statement made the statement that we are within striking distance of eliminating HIV transmission, that we have the science and we have the treatments. And that may be a broad statement for the broader community, but I want you to speak to how that impacts our community and what that really says. So I'll start, if we just go around my circle on the screen, we can start with Lamont Anthony Wells, Reverend Lamont Anthony Wells, who is the Executive Director of the Network of ELCA Colleges and Universities.
Good evening, everybody. Again, it's great to be here and to share with everyone this evening. Something that is so dear to my heart, particularly because of, as a religious and clergy person, seeing the church's response and sometimes lack thereof regarding HIV and AIDS and support of its members and people living with it. It's something that concerns me and has always concerned me for many, many years. Concerning what President Biden talked about on yesterday and what we've been kind of anticipating what might happen in the days to come, I think it's time more than ever for us to stand guard and stand ready to be apt to respond and to gather our community and to keep our communities concerns at the forefront of each other and our government, to make sure that best practices are kept and an amplified level of support is given towards the necessary resources to help our communities. So I think that is one thing that I think is key and important. It's just got to be on guard because we don't know what the transformations will come in this next administration.
Thank you. Thank you so much. Dr. Burley, Ulysses Burley III, who is head of Global Health and Human Rights active advocate and founder of You Be the Cure, LLC.
Thank you, Reverend Dr. Wood. I echo Reverend Lamont Wells's comments regarding President Biden's statements during World AIDS Day to say that we certainly have come a long way in the fight to end HIV and AIDS, especially as it relates to the science and the medicine, but we still have a long way to go. It's become popular to make statements to the effect of we have all of the scientific and medical tools that we need to end the HIV and AIDS epidemic. We just need the will to do it. And while well intentioned, I often push back on statements like that because, as somebody who is trained in immunology and whose primary portfolio right now is around HIV vaccines, I know that we have never ended a pandemic, a disease without either a cure or a vaccine. And we don't have either for HIV. And so while we have many tools that have helped to extend the life of people living with HIV, that has helped us to be able to prevent people from acquiring HIV, we still need to add tools to our prevention and treatment toolbox before we can realize the end of HIV and AIDS as a public health crisis. And we still need the will to do so. And so I commend this presidency, President Biden and Vice President Harris, for their commitment to HIV and AIDS throughout their term. We likely have darker days ahead, but I'm clear that we, regardless of who's in office, we don't currently have all of the tools that we need to end the epidemic, and there's still more work to be done.
Thank you. Thank you so much. Defina Ward, who is the Executive Director of the Southern AIDS Coalition. We welcome you tonight.
Thank you so much, Reverend Dr. Wood, and thank you to my fellow panelists as well. Oh, it's such a big question when we talk about where we can be in this moment with the treatment that we have available, the science that we have available. We have these things, and to Dr. Burley's point, there's more that's necessary. But another piece of what's missing are the fact that we don't have all the policies we need. We don't have the access that we need in many of our communities. Our work at Southern AIDS Coalition is focused on the Southern United States. And we know that the Southern states, particularly the Deep South states, are where we're seeing the greatest rates of HIV, and we're seeing disproportionate rates of AIDS-related deaths in Southern states. And we're also seeing a lack of access to prevention tools like pre-exposure prophylaxis in Southern states, particularly for Black folks and particularly for women. And so there are a number of issues at play that keep us from getting to this point of where we're ending this HIV epidemic. I talk about the work of the South because it's so critically important, I think, for this conversation, as we're often touted as well as the Bible Belt. And what does that mean when we talk about HIV disparities in Southern states and the greater landscape of disparities or historic systems of injustice, and those things cannot be pulled apart. So if we're going to have conversations about HIV, about ending the epidemic, then we have to really dig into historically why we're seeing rates disproportionately in our communities and in this particular region. We're greatly appreciative of the work of the Biden administration, and I'm honored to sit on the Presidential Advisory Council on HIV and AIDS under this administration, and also realize that states hold a lot of power and a range of disparities we're seeing, like a lack of Medicaid expansion in 7 of our Southern states. This is perpetuating the harm that we're seeing when it comes to the disproportionate impact of HIV on certain communities and on historically marginalized communities. So we have what we need, and we have a lot more work to do. And there have to be more calls to action and more changes in policy and practice to really get us to a point where we can celebrate having ended HIV injustice and disparities in this country.
Yeah. Thank you. Thank you so much. And finally, last but not least, Reverend Nancy Kingwood Smalls of the Mount Airy Baptist Church, who is Chief Executive Officer at GBAPP, the Greater Bridgeport Area Prevention Program. Good evening.
Good evening. Good evening to everyone. And thank you so much, Dr. Turner Wood. We are delighted to be having this important conversation, especially that we have a new administration that will take office soon. As it relates to your question, I do believe that there are some tools in place, but also tools and policies are just not enough. We need funding in place. We are at GBAP, we are the regional lead for Part A services, where we provide case management services, emergency financial assistance, housing. We help pay for utilities. We help pay for food for those that are living with HIV and AIDS. And throughout my career, that's going on a little bit over 30 years, we've seen a lot of policy changes. I also want to kind of shout out President Obama, because we did not have a national HIV strategy until his administration. And so with this current administration, I do believe President Biden and Vice President Harris are and were committed to providing some resources in place, but also just raising awareness. As we move forward to the new administration, I don't quite know where we stand just yet. And so I am concerned that people on the local levels may fall out of care if resources are not in place. Thank you.
Okay, thank you. Thank you all so much. So with that in mind, I'm going to open this up for anyone. There's been some alluding to what we suspect or what we might imagine would be ahead in this new administration. But does anyone have any clearer thoughts on where you think this might be going and what we might need to do with that in mind, even looking at this administration before and how it handled public health issues? And I'm opening it up to anyone who might want to discuss that.
Yeah, so I can jump in. My good colleague and friend and sister, Dafina Ward, mentioned that she currently serves on the Presidential Advisory Council on HIV and AIDS. I previously served on PACHA under the Obama administration and was a part of the team that updated the National HIV and AIDS Strategy for 2015 that Reverend Kingwood referenced. And it was my intention to continue to serve under the Clinton administration because we all thought that we were headed in that direction. As we know, that isn't how the outcome happened. And me and 5 other of my PACHA colleagues resigned from the Trump administration in protest because we quickly got a preview of what his position was going to be, not just on HIV and AIDS, but the access to health care in general, with the multiple attempts to repeal the Affordable Care Act, multiple failed attempts. And from that point, we then saw him dismiss all of the Presidential Advisory Council on HIV and AIDS, and then not reestablish that council. The Office of National AIDS Policy at the White House ceased to exist, which meant that the National HIV and AIDS Strategy that me and my colleagues had just updated became a document on a shelf. And the types of events that happened on the West Lawn yesterday in commemoration of World AIDS Day became relics under the past administration. And so if that was any preview of what's in front of us, especially since this incoming administration is more emboldened by hate, is less challenged this time around, we should all be worried about what is ahead of us. And a part of what I hope this conversation does is it connects all of our individual issues together to note that this isn't just a conversation about HIV and AIDS. It's a conversation about sexual and reproductive health rights. It's a conversation about the humanity of people with diverse identities. It's the conversation about who gets to decide what is faith and who is included in faith and God's love. And so it's a number of different issues because HIV and AIDS is intersectional. And I think that we're going to have to all unite under those intersections to get through the next 4 years and beyond.
I'd like to also say, I think that under, I think some of us, many of us, all of us maybe, anxious in a way. But to Dr. Burley's point, right, now we know who we're dealing with fully, right? So I think there's some things that I think that we could pay attention to differently, because coming into what I believe in this next administration or incoming administration, there are individuals that are more apt and ready to be bolder about their antagonism towards what we know should be rights for everyone, healthcare and all those kinds of things, and they still consider it a privilege that they can take away or to monitor or to control in some kind of way. And I think we have to be ready for that. And I think particularly from a faith-based perspective, I'm really concerned about how faith will respond to, faith institutions will respond to the different kinds of things that might occur. I believe that this level of conservatism and populism and this antagonism towards humanity is going to be something that is going to occur and grow, which means for those of us who know, in my tradition, Jesus as Christian, as the true wealth of what he is and what he espoused, will have to lift that up strongly and really lift up the gospel in a true way, and over and against those who claim or try to stake a claim to what we know as God's right or God's will for everyone.
I think I would just add to that. What I've been saying to folks who've been having these conversations, because we don't know. We know what we know from first time around, and we know now it's bolder and potentially much more dangerous. We have to stay focused. And I think that's going to be critically important, because there's so many disruptions along the way. And I think we have to be very clear on what our priorities are, to Reverend Kingwood's point around the protection of resources, the funding, like what is it that we're trying to protect? What do we want to not go away? And where do we need to put our energy? How do we make sure people maintain their medication and we can keep people in care? And it's not going to be a one size fits all solution. And I think we have to be prepared to be strategic in a new way. It's my hope that the faith community will not allow public health to be weaponized, will not allow faith to be weaponized, as we've seen happen along the way to get us to this point. And so I think this is definitely an all hands on deck moment, an intersectional approach that's absolutely necessary. And it's going to take everyone being engaged, but it's definitely going to take a level of focus. I really appreciate Dr. Burley sharing about the experience of the movement of the resignations from Pacha under the first term of our president-elect, and also recognizing that we also saw the federal Ending the HIV Epidemic Initiative come up during that administration as well. And so where then are those opportunities to identify messengers, to have these strategic dialogues around what we maintain as we move forward? And so I do think there's going to have to be a range of approaches that we're going to have to take, and to do so boldly and collaboratively.
Mm-hmm. Okay. All right, thank you. Then with that in mind, let's shift it a little bit. If we suspect, and as you said, we have to wait and see because we really don't know what's going to happen, but we have an idea of what could happen based on what's transpired already. But if we suspect that we may not have at least the level of support that we have now at the federal level, then that would behoove us in the faith community to have to even step up even more than what's been done in the past. And so I want to hear you talk a little bit about that, dealing a little bit with the issue of stigma and shame and how we hurt ourselves with that, but also from the leadership standpoint of weaponizing, as you said, or allowing the issue to be weaponized within the church community. I can remember as the head of a women's ministry years ago when HIV and AIDS was new on the scene and everyone was a little afraid to talk about it. But we had it as a survey as one of our issues. What is this something you want to discuss more? Do you want more information? And overwhelmingly, the women within and the women's ministry said, yes, we need more information. We need to understand what's happening. We need to know how to prevention and all of that. And so we called in 2 experts. We scheduled the evening for everybody to come out, get their questions answered, and come together. And on that evening, not even 5 people showed up. And so I think the stigma around they didn't want to be seen as wanting to know the information. And the stigma then caused us to be right where we were in the first place. So if you could talk about that, and then also the issue of it being weaponized in the church with leaders, with faith leaders who may not feel comfortable or who may shy away from the issue for various reasons.
I think in my experience with engaging the faith community here in Bridgeport, in the greater Bridgeport area, we have successfully engaged 85 houses of worship and HIV prevention and care services. And some of those partnerships came through personal relationships, but also that we created material in which that we could actually train senior clergy and have these brutally honest conversations. What does HIV look like in your congregation and in your community? Where do you stand as it relates to same gender loving individuals and couples? And a couple of those conversations were very, very intense. And I knew from the beginning who was going to be on board. But I did have a couple surprises. And so we worked with the ones that wanted to work with us. And we also encouraged them to tell your peers, not us call them, you call them, and invite them. And so as we continue to engage and mobilize the faith community, we did create a task force of senior pastors and some lay ministers as well. And we know that the message from the pulpit goes beyond the doors of the church. It goes out into the community. How many times has a congregant said, hey, guess what pastor said today in church? And so we need the leadership there. But one of the things that we found very interesting, and a few of the pastors shared with us in private, that they had the desire to engage their congregation through their sermons, but they didn't have the information. And so we still had to do HIV 101, where we created this environment. It's okay to ask. There's no dumb questions. There's no stupid question. We want to equip you with the information that can actually save somebody's life. And so we even had testing in the pulpits. We've done that. And so we are at this place now where we're over 40 years in this thing, you know. And again, it has come back around where we need the support of the senior leadership to get on board again. I am very concerned about the appointment of the incoming Secretary of Health and Human Services, because we know policy shifts and drives funding. And if it's not a priority for them, it needs to be a priority for us. Because when you look at the statistics and you look at the numbers, we're there. We are also unwavering in the fact that unaddressed historical trauma leads to poor health outcomes and premature deaths in Black and Brown communities. We need to connect this back to our ancestors. We need to connect this back. Why don't we sometimes trust medical institutions? And I think these are the conversations that can happen within the faith community.
Absolutely. And we have legitimate reasons for not trusting. Sometimes we've got a history that speaks to that. Does anybody else want to speak to that issue? I also want to get even more specific as we drill down a little bit about what do those messages need to be that you referenced, Reverend Kingwood? What does a pastor say? What does a faith leader say to the congregation? Because I think you're right. Sometimes the heart is there, but the information is not available or easily communicated, and we need help with that.
I would say that, and everything to what Reverend Kingwood just said is, I think, is key and important. I really shouldn't add, but I just think in my head, the concern that I have about the faith community's response to this, and particularly reducing stigma, is that our attention span is often so small, like culturally in our world, right? Like that we shift from one thing and we go to the next sexiest thing, or we're so much that is getting to us. But getting back to the basics and focusing, I think are going to have to be some of the key strategies that we do. To Reverend Kingwood's point, I think education is still key and priority. There are a lot of people that still don't know the basic foundational rules, or not rules, but understandings, and even some of the breakthroughs that have occurred, right? People sometimes are living as if there is a cure, right? Because of certain things that are preventative, or assisting the lack of the transmission. So I think that getting back to that, and that's not a lot of resource, right? That's our mouths, that's an understanding, that's not like big bucks, right, per se, but that's getting to communities, and particularly, I want to say, concerning to the Black church, right? Because our numbers are still rising in certain communities and areas, and coming from a white denomination, right, where certain numbers amongst white populations supposedly are decreasing, so the care kind of diminishes in a way, but it's still an issue for communities of color. And that's something that we have to own and live up to, and cause ourselves to have to be more informed about and have deeper and better responses to. And I think it's going to also have to cause us to not necessarily to create levels of intersectionality and not segregate ourselves, and to find ways of true partnership and true community and true collaboration. I know that's hard to hear and to say after this last election about how people voted in their different demographics, but it's something that is key, and I think will help our strategy to move forward to continue to get to zero.
I would just add to that, in my experience in working in prevention in the South, oftentimes in talking with faith leaders, it wasn't just HIV as a conversation that scared them. It was all the other things that they thought came with it. So if I talk about HIV, do I then need to talk about my position on homosexuality? Do I then also have to talk about sex and substance use, and how we feel about folks of diverse gender expressions, like all those things, that it felt like a snowball and overwhelming. And I think that is part of it, is the equipping with the education that allows leaders to be able to have those hard conversations first in a space where they can learn and be in dialogue with peers, which has been helpful in spaces that I've worked in. But just that acknowledgement that it is more than a conversation about HIV as a condition. It is about how it's been stigmatized, how communities have been stigmatized, and how that word weaponized again is so often how scripture and teaching is used in a way to make folks feel unwelcome and unloved, and how all of that is just wrapped into one big package when we talk about having these conversations in faith spaces, and that we have to give folks the tools to be able to have a broad range of conversation in order to address it effectively in our faith spaces.
Absolutely. And added to that, I mean, I think you're right that complications are the fact that those who are at greatest risk are some of the people in the community that the church has not done well with in terms of welcoming or openly addressing some of the issues. So when you look at the LGBTQ community, you look at transgender women, you look at youth ages 13 to 24, and you look at people who inject drugs, those are people not necessarily connected to the church community for various reasons, but those are also the people who are most impacted according to the data and the statistics. And so we've got a lot of work to do. I still want to talk a little bit more about the messaging in terms, this is Woman Preach, and one of the things that we stress and emphasize is what we say from the pulpit, what messages we send out there. So if you all can help us a little bit with with even how to present the messages that would embrace communities that are not necessarily always embraced, particularly in the Black church, but in the church at large. I know that may be a little challenging, but let's see what we can do with that.
Yeah, Reverend Dr. Turner Wood, I appreciate your naming the demographics of people who have often been left out of our churches. And because of that, I think that we have to rethink the church. Mm-hmm. We have to rethink what church is and who church is if we are to truly reach the people who need to be reached with these messages of love and inclusion and compassion and information around HIV and AIDS. Young people, people with diverse identities are disconnected from church, but that doesn't necessarily mean that they are disconnected from faith.
Right.
And we are trending in a direction where in our country, we will have more people who identify with no faith, the nones, than people who identify with a faith. What then becomes of the traditional setting of church where we rely on faith leaders to communicate a certain message to the masses if the masses are no longer inside the church? And so I think we have to be expansive in what we call church, and understand that those people who have maybe been disconnected because of all of the reasons that you mentioned are people who still have deep faith, and people who still want to access their deep faith, which means that we might need to meet the people where they are now, right? And so that might be worship in a bar, or worship in a ballroom community, or worship, fill in the blank. And so I appreciate you naming that. And I think that we have a responsibility as faith leaders to think outside of the four walls of the traditional church, because the people who we need to reach might not be there. To your latter question about messaging, I think there's still a lot of good that faith leaders can do, even without or with a cursory understanding of HIV and AIDS, right? Because at the crux of the epidemic is stigma. And, people are no longer dying from HIV. People are dying from stigma, HIV-related stigma that prevents people from accessing treatments and prevention and information. And I think that the gospel, in the Christian tradition is ripe with examples of inclusion and love and access to the least of these. I think it's just how we present it. And one of the things that, a preacher could do that would benefit the movement to ending HIV and AIDS is to think about how we communicate healing particularly for people living with HIV and incurable disease. Oftentimes the stories and the messages of healing in the Bible, in the New Testament, in the Gospels are these complete healings, right? The blind man ain't blind no more. I can see miraculously. The woman with the issue of blood miraculously isn't bleeding anymore. And those messages might not land, might not resonate with a person living with HIV where we don't have a cure. But for them, healing looks like having access to their antiretroviral medication that has suppressed the virus in their body so that they're healthy and so that they can keep their loved ones healthy. And so then we need to recontextualize what healing looks like in a theological sense for people living with HIV and AIDS, noting that healing as it's presented on face value might not exactly land with people living with HIV. And so I think that's one way where you can take text. You don't have to have a deep understanding of HIV and AIDS to be able to say healing for you might look like having access to your medication, or healing for you might look like having access to PrEP to prevent HIV transmission, and thinking about things differently.
Anyone else before I move on? I'm gonna. Oh, go ahead.
I would just add quickly, one of our colleagues, Dr. Tatiana Moten, the first person I ever heard say everyone has a status, right? This whole idea of like everybody has an HIV status.
Yeah.
And so really simplifying this conversation, getting away from the stigma of whatever your status may be, everyone has an HIV status, and talking about it from that lens, I think is very important, because it's not so much about what it is, but it's about knowing it, so that you can have your healing and you can be healthy, whatever that status may be. And I think that's a really important part of the conversation.
And I'd like to also, I think that talking about what will we preach, how will we preach, what shall we say? And I think if getting back to also the basics of affirming God's unconditional love, I think we have moved in a time, again, it's not that we haven't been here before, of putting conditions on what is right and what is wrong. We've been so polarizing, right? It's Democrat, Republican. So there is no unity at all, right? We can't even fake it anymore. But particularly when it comes to what thus says the Lord, if you will, right? And what is required of us is the unconditional love, right? And it's not love you because you wear red or didn't wear blue today. It is love you no matter what you have, those kinds of things. And that is something that has to be entered into the theological assertions in pulpits and mosques and temples and to Dr. Burley's point, into the bars, into the clubs, or to wherever there is this level of not just do what you want, but really the move is God's unconditional love. And that's how we operate, and that's how we move, and that's how we'll stick. All inclusive and not exclusive.
Mm-hmm. Can I just say also that that's why it's important, I think, to bring the gospel and the unconditional love into these other spaces. Last night at one of the World AIDS Day event, there was a trans woman there, and it happened to be her birthday. And so we stopped the program and sang happy birthday. And I went up to her and hugged her. She collapsed like in my arms and said, I haven't been hugged in years. Mm. And I whispered in her ear and said, I love you. And so does God. And she was very guarded for a moment. And then she embraced me again. It's in those times and in those spaces that I think we can have more impact on people, but also sharing our faith. You don't have to beat them up with the Bible or make them feel guilty for not coming to church. It's these third spaces that where people just show up, even on our syringe exchange van. We just meet people where they are unconditionally and just love on them. Mm-hmm. Offer resources, if they need them, but also just love on them. And oftentimes they feel that the church has either forgotten about them or just don't care at all. Mm-hmm.
Mm-hmm. What's interesting, thank you. What's interesting too, I mentioned that list, LGBTQ, transgender, and people who inject drugs as the most high risk. What I left off of the list that was offered through NHAS, I think, is Black women and Black, Latino, and men. Black women make up the majority of many African American congregations, right? And then Black men as well, and Latino men certainly in Hispanic congregations. To leave these groups out, to not let me say it this way, to not give time to HIV and AIDS and sexual health and reproductive health and all of that, is to also not just do a disservice to those communities that are on the margins, but it's also to do a disservice to the communities that are sitting right in front of us, who do come to church and who do show up and who do pay tithes and participate. And so I think that piece of it needs to be added to the mix so that those of us in leadership in the churches who are not as familiar as you all are, don't stigmatize just those or ostracize just those groups without recognizing that to ostracize the subject, to not deal with the subject, is to also ostracize those who are sitting in front of us every Sunday morning. So, okay. I want to remind everyone, those who are listening, that we will have a Q&A session in just a little while. So if you can already send your questions in on in the chat space or whatever the other spaces are that are provided for you, we look forward to hearing from you when it comes to that moment of Q&A. I want to ask the panel now, as you, what do you see now as probably the most pressing issue that you are confronted with on a day-to-day basis?
For me, it's the social determinants of health. It's not HIV and AIDS itself. It's those structural conditions in which people are born and work and grow and age and worship.
Talk a little, because I don't know that everybody knows what social determinants of health are.
Yeah, certainly. So we use the word intersectionality a lot, coined by our good sister, Dr. Kimberly Crenshaw. And we know that intersectionality is this unified system of oppression of race and sex and gender and faith and, fill in the blank. And together, these collective social constructs contribute to oppress specific groups of people. When that unified system of oppression manifests in the form of public health, we call those the social determinants of health. Things that we can't necessarily control, where a person is born, where they live. Dafina eloquently mentioned the grave situation in the South because of just where people live. The state that I was born in didn't expand Medicare. And so right away, I'm at a disadvantage from people who were born in some other location in the country because of the policy that exists in that place. And so the social determinants of health are what confront me in my work daily. And it's what the data suggests is the most important aspect of defeating HIV and AIDS as a public health crisis. We have data that tells us that modifiable health outcomes aren't impacted in clinical settings. Only about 10 to 20% of wellness takes place in a hospital or a laboratory. The other 80 to 90% of wellness happens in people's communities, whether or not you have access to fresh fruits and vegetables, whether you have access to healthcare, can you, wake up and not be, next to a factory when you walk into school. Those types of things are what contribute to people's health outcomes. But when you look at the investment, we overinvest in a healthcare system that hasn't produced better outcomes over the last 20 years, despite the cost going up. And we underinvest in communities, despite knowing that health outcomes happen in communities. And so we've got to shift the investment and at least make it equitable to such that the burden of the community is impacted in the way in which we've thrown dollars at, the medicines, and those things have been important and we need them. But if people can't access them because of where they live or where they were born, then what's the point of the science? And so we've got to address the social determinants of health. And that's really an opportunity for communities of faith, because it means that you don't have to be a scientist or a physician or a pharmacist to impact the HIV and AIDS epidemic. You just have to be somebody who's trying to make your community more equitable for people who are most vulnerable to HIV, people who are disadvantaged. And that's how you then work to end the HIV and AIDS epidemic. And so we've got to prioritize the social determinants of health, which might not look like, testing, prevention, treatment, and care. It might look like making sure people have housing, making sure they have something to eat, making sure that they can have access to healthcare outside of an emergency room, making sure that they can be competitive in literacy and education. and making sure that they have access to health careers, because we need more for physicians and nurses and pharmacists and techs who look like us, to handle our own issues and our own problems.
Good. And that shows up then in our ministries and our planning and programming throughout the year, and it can show up in our messages. But I love the way that you put that. On the ground, for the others who haven't spoken yet, what are your day-to-day challenges, greatest challenges?
I'll go. One of the clear things that I am mindful of, kind of collecting the missional identity of 28 colleges and universities across the U.S. and Canada, is this sense of clearing the way or out of misinformation, and helping my institutions and those things to know their power and their purpose. I happen to work in private higher education institutions that are acting like they have to respond like public institutions that have to operate under certain, state and federal guidelines, or we all operate under federal guidelines, but really there's a level of independence that we have and the opportunities that we have. But many of our boards are reacting to the things that are going on in the world around us, like removing DEI. There's no need to even remove that from any of our institutions. And it really goes against our private missions that we were founded upon and should be living into. So I think helping institutions stay key to their mission, and that would relate to the churches and mosques and temples as well, I think is a thing. I think people are getting confused with what their rights are. Like, I think there's so much misinformation out here that people don't know the power that they possess. And I think people are feeling, and I hate to use this word, but impotent in a way that they are powerless to do some of the things that really they have been called to do. So kind of helping, so the thing that I'm dealing with on the ground is helping institutions primarily to see their own power and to see their own ability to make the change and the transformation that we say we want to have as a part of our identity. So that's one of the key things. I see a lot of people are just, like kind of putting like hands up and just giving up, and it's not the time to give up. Actually, it's the time now for those groups and institutions to stand bolder, to educate properly, and to add to the value of our world around us.
Thank you. I would just add to that. For me, if I had to sum it up, I would say on a day-to-day basis, I'm seeing a weary workforce. People are tired. Mm-hmm. And, it goes back very far, but I specifically think about the deployment to address COVID that so many of our communities had to do, and some in public health, community-based organizations having to shift their focus in that way. And it has just been nonstop. Since then, Dr. Burley brought up the social determinants of health. Our community-based organizations, with and without resources, are addressing so many things. Mm-hmm. They're not just making sure folks have prevention and treatment, they're making sure they have food and a safe place to sleep and getting them job training and all these things, often without those programs being adequately resourced. They're also dealing with what we call policy whack-a-mole, where it seems like every day something new is popping up to make their jobs harder. And then the fact that we're seeing more restrictions around how funding can be utilized. And our community leaders are saying to us, we know what works. We know what's going to work for the people that we serve. But you're saying we can't buy them food, and we can't incentivize, and we can't do this and that. And so just making the jobs harder. So I think our workforce is weary. And there is a huge opportunity, I believe, for churches to better support community-driven efforts to address HIV and the full range of issues and needs that communities have that intersect with HIV. So it is so much bigger than just HIV. And we do have to truly get to those systemic challenges that our workforce is dealing with every day without adequate support and resources to do so.
I would also like to add, I do agree regarding the social determinants of health, but what we see on a daily basis is the increased amount of rent that people are expected to pay on limited incomes. And yes, through some of our Ryan White funding, we help pay back rent or pay security, or we try, to maximize our resources, but it's challenging. And the amount of trauma
Mm-hmm.
connected to just living, and it's not really living, it's surviving.
Yeah.
We're trying our best to give out food cards daily, to give out groceries daily, to provide medical transportation. And yes, I believe our frontline and our program staff are tired and literally a couple of paychecks away from being in our system of care.
Right.
And so I don't have the answer, but again, it goes back to resources, it goes back to policy, it goes back to letting the people in the community, in the faith community, and the community at large really know what's going on. We're so easy to just push people away and say, you got what you got.
Yeah.
You have what you have because of whatever reason. But we're seeing this on a daily basis. People cannot make ends meet. And that causes other things in their lives, whether it's to continue to be an active addiction, whether it's drinking, whether it's multiple partners. We have some women that are in our system of care that are, engaging in sexual activity with their landlords because they cannot afford to pay the rent.
Mm.
We have some males around our city that are paying sex workers additional money not to use condoms.
Mm.
And because they're really trying to make $1 out of 15 cents.
Yeah.
And so until some of these other issues are addressed, whether it's through policy, whether it's through just having conversation and raising awareness, we're spinning our wheels.
Mm-hmm.
Yeah.
And trauma. I mean, you use that word. We have normalized trauma, I think, so that it's part of our existence, or part of so many people's existence on a day-to-day basis, that living the way that they live, which is unconscionable, has now just become a normal way of life. And that is unconscionable for those of us who are able to do something about it. I want to take a moment here. Thank you all so much for sharing. I want to take a moment here and turn it back over to our tech people to move into, I think Dr. Janetta Hatcher is coming at this time to have a message from Woman Preach.
All right. Hello, everyone, and welcome again to this great conversation. We're so glad that you gave us a part of your Monday night, and this is great work. This has been great conversation. I was reminded about 2 or 3 months ago, there's a lady that lives here, Metro Detroit, and she has an organization that's been active for about 20 years or so called Gospel Against AIDS. And I was pretty naive and just assumed that this was still not an issue. And just a conversation, and the people that actually showed up and got tested just reminded me and us, and tonight is doing the same thing, of all of the work that is yet to be done. Woman Preach, you all, does great work. I, as a pastor, often when I get to this moment, and I'll tell you right now, I'm going to ask that you would partner with us in doing this work. But so often as a pastor, before I started my own church, I would, when it came time to ask for, an offering or the giving time, as it were, I had some hesitation. But when I started my own church, it was easier. You know why? Because I could say, I want you to give, not because it's protocol, not because it's just what we do, but I was able to say, I want you to give because of what we do in the community. I want you to give because we tithe the 10th. And so I was able to ask with a good conscience, because I understood that what I was asking for is to support what we're doing, what we've been called to do. And so tonight, that's really what I want to ask of you. Don't know whether some of you are already givers. We pray that you are. But we did not want to miss the opportunity, particularly with tomorrow being a Giving Tuesday. We did not want to miss the opportunity to ask that you would continue to support this work. What we do is really prepare people, women and men. We train them to preach in several different through several different avenues. We also host events like this that, as you know, doesn't cost anything for you, but we need your help. Tomorrow, I will have the daunting task to sit with other, in this case, brother pastors and preachers, and talk about where do we go from here as a church, as a community. What kind of preaching do we do now in lieu of this new administration? And I've been wondering what I would say. And I don't have all of the answers yet, but organizations like Woman Preach helps all of us to prepare to preach prophetically in times like these. So would you consider giving? There's an opportunity for you to give one time. The link has been placed. I put it on Facebook. It's here in the link on StreamYard. It's available to you to give a one-time gift if you so decide. But let me tell you what we really want, and I'll let you go. We really want you to believe so much in this work, and it's valuable, you all. You cannot even put a price tag on what the vision of Dr. Bridgman and what our president, Dion, and this board and the staff, the work that they do day in and day out. Often we will get to determine who we want to give to. Some of you are now, I've gotten as a church pastor, I've gotten, text messages and emails saying, hey, we're planning our giving for 2025. So in your planning, we ask that you would consider being partner with us in this work. In your planning, we ask that you would be a monthly giver. You may say, I only have like $25. I can only do $30 or $50 a month. Or maybe someone said, I can only do 20. That really will be between you and God, you and your household. But I want you to partner with us, to walk hand in hand with us as we journey through these next 4 years. We don't know what it will entail, but we know that Woman Preach will be there every step of the way, training people to preach. Please join us. Be a monthly partner and help us to do this great work. Thank you, Dr. Woods, and thank our panelists for being here. And God bless you all for this opportunity. We'll now go into our Q&A.
Thank you. Thank you so much, Dr. Hatcher, for that appeal. And we pray that everybody will govern themselves accordingly. We have a couple of questions and answers. Reverend Tierney Ridley is managing things behind the scenes. So here's the first question. Where do we go from here? And what can we do working in the field or as individuals living with the virus to help advocate?
I'm happy to start if that's okay as far as a response. I encourage you to get involved with organizations in your community. If there are organizations that are serving folks living with HIV, if you yourself are living with HIV and want to be involved, I know that you would be welcome with open arms into organizations whose mission is focused on addressing HIV in your community. I also encourage you to look into advocacy training opportunities. Lawmakers need to hear from the folks who put them in office. Constituents' voices need to be loud. So get educated about who your elected officials are and what their positions are. And there are a range of opportunities for advocacy training. Please check out Southern AIDS Coalition. We are Southern focused, but if you're not in the South, we can direct you to partners who are doing great work. There are a lot of opportunities to become an advocate and a voice. And as we've been talking about today, it is about so much more than HIV. So it's critically important to know the positions of those who are making decisions in your community and to put your voice into the mix on what your expectations are to make sure that folks in your community have the resources that they need.
Can I just jump in for a second? Hi, Huisha. It's good to know that you're on. And your question is very important. Huisha is a Ryan White case manager, and we are getting some. We received some news about our funding and about the dismantling of regional leads in our community. We have jobs at risk, and our region is at risk. And so your question is a very good question, from since you work in the field, as well as you have access to persons living with HIV. And that advocacy piece is crucial. It's crucial to the fight for resources, to allow people to their voices to be heard. People with HIV can tell stories and testimonies about how policies affect their everyday lives. So I didn't know you were on, so I'm glad you are. Thank you.
Thank you. Dr. Burley, or go ahead.
Yeah, thank you. I want to add to something we often shy away from because of medical abuse, medical bias, medical stigma, especially in Black and Brown communities, is the participation in research, specifically clinical trials. So I serve as the principal investigator of the HIV Vaccine Trials Network Faith Initiative. And the HIV Vaccine Trials Network is exactly what it sounds like. It's the largest entity globally responsible for developing and evaluating a safe and effective HIV vaccine, which we do not have yet. But in order for us to get there, we have to have a diverse population of people who are willing to participate in research to help us get there. And that includes people who are not living with HIV, as well as people who are living with HIV, as evidenced by one of our most recent breakthroughs in broadly neutralizing antibodies, or BNABs, which we are currently studying as a potential additional prevention tool in the future for people who are not living with HIV and AIDS. Those antibodies were identified in people who are living with HIV and AIDS, whose immune systems have naturally developed this response against the HIV virus without the assistance of medication. And we wouldn't know these broadly neutralizing antibodies exist if it were not for people living with HIV who were willing to contribute to research, who are now literally providing us with the tools to possibly prevent more acquisition of HIV in the future. And so find out more about clinical trials in your areas. If you live anywhere where there's an academic center, there's likely an opportunity for you to participate in a clinical trial. They all take place under informed consent, and I emphasize the informed part because you can't consent to something that you don't understand. And we take it very seriously at the HPT and making sure that communities are involved in the clinical trial process from design all the way to the production of a potential product. So be open to learning more about the opportunities available for clinical research in HIV, and be a part of the solution.
May I please piggyback off of Dr. Burley for one moment? I'm sorry, I didn't see you coming off of mute. Another area where we need to push community involvement more are serving on boards of directors and planning councils. Federally qualified health centers, their boards have to be at least, I believe, 51% patient members on the boards. And I think so often with our FQHCs, our community health centers, those boards are supposed to include patient and community voices. And those are spaces where you can advocate. And so I would just really encourage folks who may be on or watching this to find out what opportunities for leadership exist with boards of directors at places where you receive services, as well as with planning councils and other public health systems in your community.
Thank you.
Definitely, to everything everyone just said. And I think we're in Advent season right now, and there's a term that we'll start using: awake, 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 O Zion, right? Like, be awake, right? I know woke is not in vogue right now, but it is time to be woke, right? It is time to be awake, and to do all of the things that were just mentioned, right? Learn about the things that are necessary to support, right? Actually support, give, donate. I think all of those are key and important. But I also think it's also time for us to in this season, where do we go from here, right? Is to reduce not just the stigmas, but also the fears, right? So there are going to have to be some more bold steps, and all of us working together to do some things to align with not just local campaigns, but also see ourselves connected to a globe. This as connected still to as a global issue, right? We can't forget about not just our brothers and sisters and siblings elsewhere. And so again, I think it's about creating a level of connectivity and becoming more informed and staying fresh about what's going on and finding new ways to get involved, but giving definitely and participating strongly.
Thank you. Thank you. All great responses. Is there another question, Tierney? Reverend Tierney? Can you speak on the HHS legislation for HIV positive organ transplants, liver and kidney in particular, recipients in African American communities? That may be, does anybody feel comfortable speaking on that one?
Yeah, I can take that. I don't know that I expected to have a question that specific from this audience, but I appreciate it. It's an excellent question. So I think about 10 years ago, the HOPE Act was presented and put into law. HOPE stands for HIV Organ Policy Equity. And it really was the beginning of making organ transplants for people living with HIV more accessible, because people living with HIV are also people now aging with HIV. And with living and with aging comes our bodies begin to break down. And so that happened 10 years ago. But throughout that 10 years, the HOPE Act has been expanded. And so initially it only involved kidneys. And then I think in 2020, it was expanded to all organs. And then just last month in November, HHS announced that IRBs, institutional review boards, and clinical research approval requirements were no longer required for kidney and liver transplants between HIV positive donors and recipients. And this is because we now have research that suggests that these transplants are safe and effective. And so that removes yet another barrier that was in place that will make organ transplantation for people living with HIV more accessible. Now, in terms of Black people specifically, race and ethnicity and sexual orientation and gender expression and all of these things don't play a part in matching donor organs and tissue transplants. It's based on blood type, body size, just how sick the person is, what's the proximity to the actual donor, tissue type, so on and so forth. That being said, we need more people of color who are organ donors, because we know that Black people are overrepresented in the HIV epidemic in our country. And we also know that people living with HIV, their organs tend to fail more quickly than people not living with HIV, meaning that they're more likely to need organ transplants earlier in life. And so if a disproportionate number of those people are Black and brown people, it does absolutely help for there to then be Black and brown donors to pull from, because one of the important factors in matching organ transplants is compatibility, and a lot of that compatibility is based on a shared genetic background, which is often, sometimes found among people with the same race and ethnicity. And so, so the access has been increased, but we need more Black and brown donors, because a large majority of people living with HIV are Black or brown, and therefore will likely be the people who will most benefit from organ transplants. But it's also important to note that people of all races mix and match organ donors and recipients. And so, again, it's us being willing to participate in the scientific process, whether that's clinical research or organ donation, so that we can help to extend the life of our brothers and sisters living with HIV. I hope that answers your question.
Thank you. Thank you. We have one final question. If you were sitting in the congregation, what would you most like to hear from the pulpit given this conversation? And we'll end with this question, and we'll have our panel give us a final statement after this. What would you most like to hear if you were sitting in the congregation, knowing what you know, with your level of expertise, your level of experience, your feet on the ground, and seeing what you see every day? Do you want me to call on you? Reverend Wells, I know you just finished, but let's start with you.
Well, I've got to do it. I've got to bring my Lutheran theology in it, and the basis of it, right? Grace, right? I really got to hear that, because there's so many things that we put on people, and I think that we have to unburden people. And I think to hear a message of freedom and grace, I think is very key and important. A lot of people feel like they've messed up. A lot of people feel like they can't go on. They don't have the opportunity, the strength to journey on, or to know which way to go or which way to turn. And I think a true gospel message, a true good news of grace, not just necessarily just absolution and, again, being wanton, but again, grace with responsibility, grace through faith, believing that God loves us unconditionally. And those living into those kinds of understandings, I think is something that I think is necessary to be shared and heard. And I don't hear that in many contexts anymore.
Thank you. Thank you. Executive Director Ward, would you speak to that, please?
That's such a good question. So I agree with the grace message. I would also love to hear some science and fact coming from the pulpit. I would love to hear a message that talks about the power of undetectable equals untransmittable, and what it means for someone's viral load to be undetectable, and the fact that they won't transmit HIV. I'd love to hear a message that talks about the power of prevention. We have to start with love. And start with the scripture. And I think what we see so often in this work is that folks will hear messages out in the street and don't think they apply to them. There is power in the words that come from the pulpit. Mm-hmm. So I would love to see or hear a message that takes truth and science and lets congregants know this applies to you in your life. And you can live this, and you can own this and have this as well. So that's where I'll stop.
Okay, that's great. Dr. Burley, how about you?
So my good brother, Reverend Wells, mentioned that we were in Advent, and I don't think it's a coincidence that this year World AIDS Day not only fell on a Sunday, but it fell on the first day of Advent. And if you grew up in a church like I grew up in, and I preach in, you preached the lectionary yesterday, and the text was Luke 21:25 through 36. And, Jesus is talking about these signs of the upheaval, the sun and the moon and the stars, and people fainting with fear. But then he gives a promise. And he says, when these things begin to take place, stand up and lift your heads because your redemption is drawing near. I think that's what I would want to hear from the pulpit today.
All right. Thank you. And finally, Reverend Kingwood Smalls.
Thank you. I think I would like to hear, I'm not alone.
Mm.
I am not the dis-ease.
Ah.
I am not the diagnosis.
Mm-hmm.
More than that, I would like to hear where resources are. Oftentimes, sometimes the church will refer the congregants or people from the community to organizations in which they have not built a relationship with. They don't know the experience that one may encounter when they go through the doors. And I think we need to do better. But if I were sitting in the congregation yesterday for World AIDS Day, that's what I would like to hear, that I'm more than my dis-ease. Had the opportunity to preach yesterday, and I preached from Philippians 1, and I went through 1 through 4, that he that has begun a good work in you shall complete it. And my sermon title was, I'm getting teary-eyed because there was a lot of people there living with HIV. It was entitled, This One Thing. This one thing. And regardless of what other people think I am, God is still at work in my life, whether I have HIV or not. That other people don't have the final say over what happens to me, because I'm still a child of God. I'm still included in the congregation, and I'm sitting here. And I'm filled with expectancy and hope. I can't imagine going to church 52 Sundays a year and not hear about my condition. So I would like to just know that I'm more than what people think I am. I'm more than a label. I'm more than a diagnosis.
Amen. Amen. I'd like to hear that too. Let me offer, thank you all for those thoughtful answers. Let me offer you a moment to sum things up. If there's anything we did not cover that you want to add, anything that you feel was left out, here's your moment to do that. And again, I'm just going to go down my screen. Actually, I'm going to start, go backwards again this time and start with Executive Director Ward. If you will come on and tell us if there's anything else you want to close out with.
Well, first, I want to thank you all for this wonderful conversation. I'm leaving feeling renewed and excited in the face of all the work that we have ahead of us. You know, what I would like to leave is that I want everyone who hears this to recognize that we do hold power. There's been a lot of conversation about what's looming, what's coming, what we don't know. But we know God's promise. And we've had some of this conversation here. And I think it's really important for us to recognize that we have power, that we have to reclaim, that we own the narrative of our lives and experiences, and that we have a responsibility to help other folks to see the power and the beauty of their own lives and experiences, whatever that might be. I have to say, Southern AIDS Coalition, please follow us on social media if you don't. We are focused on the South, but it's of national impact, because we don't end the national HIV epidemic if we don't end it in the Southern United States. And we'll be releasing an update to our Southern States Manifesto later this week, which will lay out policy priorities that we believe apply across this country when it comes to what's most critical for the lives and the well-being of those living with and impacted by HIV. So the work will continue. No matter who's in office at any level, we will be here and we will do the work. And I'm honored to be in this work with all of you. So thank you again.
Thank you. Thank you so much. Reverend Kingwood Smalls.
I would like to say that we need our churches. We need the senior pastors. We need associate ministers, we need the deacons, we need everybody. And to give a charge, almost a call to action. And one of the things I realize is that, again, churches may want to enter the fight. They may want to offer their spaces to community-based organizations or health departments. Partnerships are key. Partnerships are key to ending this epidemic. And that churches, and I think the Southern AIDS Coalition can help with this. And I know Vanessa Seal have been doing this work for a while with the bomb in Gilead. Churches need to help. We need to help churches build their infrastructure and their capacity to do this work. Whether it's through education, whether it's through helping them form a 501c3, whether it's through grant writing, whether it's through policy development or advocacy, sound the alarm. Because again, we need everybody to get to zero. Thank you so much for the invitation for me to join this important conversation tonight.
Thank you so much. We appreciate your time. Dr. Burley, would you share with us any final thoughts, please?
Sure. I'm going to cheat a little bit off of Reverend Kingwood and Daphne Ward's paper and speak to the power that is inherent in our communities. I came into this work by way of my medical training, but my greatest impact hasn't been what I've been able to do in hospitals or in laboratories. It's been what I've been able to do in community apart from my training. Medicine and science alone won't end the HIV and AIDS epidemic. We've also have to keep the faith and have faith. We've got to treat people and not just disease. And it's going to take all of us, and all of us have the power to be able to impact it in that way. To Reverend Kingwood's appeal, if you are a faith leader or a faith community who wants to get more connected with organizations that are doing work at the intersection of faith and HIV and AIDS, I invite you to learn more about the U.S. HIV and AIDS Faith Coalition. We are on social media platforms, just as you heard it, U.S. HIV and AIDS Faith Coalition. And you can Google us to visit our website to see some of the priorities that we are taking up as faith leaders who are committed not only to ending the HIV and AIDS as a public health crisis, but ending HIV-associated stigma, which would continue to persist even if we cured HIV and AIDS today. And so those opportunities are there. And then from my clinical hat, if you want to learn more about HIV clinical trial opportunities, I invite you to visit helpinhiv.org. Helpinhiv.org is the HIV Vaccine Trials Network registry, where you can learn more about the clinical trials in your area. You can sign up for a registry that will then connect you with somebody once a trial comes available within your area. And just again, thank you to Women Preachers for this tremendous opportunity to speak to all these intersections.
Thank you. Thank you so much. Last but not least, Reverend Wells, let us hear from you, please. You have to unmute.
Someone wrote in the chat, sound the alarm. And I hope after tonight's conversation that we understand this conversation as a sacred responsibility, right? That we all have to be able to use our faith, right? Because we've been called in many ways to address and be agents of healing and reconciliation and justice and all of these kinds of areas. So we've got to deal with this clinically, medically, sociologically, politically, all of those things that are necessary, which means that everybody's going to have to find their niche or their space to participate. And everybody can't pass out condoms. That's not everybody's job or whatever to do, right? We need some people that are going to be the drivers, transportation or whatever, especially in the time that's coming up, that we have to be more concerned about people who are leading areas that affect all of us. And I think that we have to be clear about that. The fight against HIV and AIDS, I think we have to understand, is not just a mere medical or sociological challenge. I think it's definitely a spiritual one as well, and how we relate to sharing the gospel, the good news message, lifting people up, unburdening them. I think it's important for us to embody the teachings that we espouse in radical ways, not just passive ways that are unhelpful, and to stand with the marginalized. I think all of those things are key. From the woman preach perspective, if you will, like the preaching capacity is to proclaim through words and actions that all people are worthy of dignity and compassion and belonging, not just in our churches, but in our world and everywhere else that they are showing up. I think that's key and important.
Amen. Amen. Thank you so much. I want to say thank you to the entire panel for your contribution tonight, for your sacrifice of time, and for sharing with us in such meaningful ways. On behalf of Dr. Valerie Bridgman, our founder, our Woman Preach founder, who has saved many women preachers and our preaching, and to our executive director, Reverend Dion Boissier, and to the entire, on behalf of the entire board, we profusely thank you for your time and your contribution. When I was in the HHS years ago, I served as speechwriter and executive director of public affairs for David Satcher during that administration. And one of the things that he always did was to quote Dr. Benjamin Elijah Mays. And one of his quotes was, "You ought to always leave a situation better than you found it. Whenever you enter a space, leave it better than you found it." And I want to say that you all indeed have left this space better than it was when we started, and you have helped countless people for the time that we've spent together tonight to go forth and to be stronger in the work that we do. I want to thank everybody who's participated by listening and asking questions and just spending the time here. This issue is not just for those who are people who are living with HIV and AIDS, but it impacts all of us, as has been mentioned over and over again on this evening. So may the Lord God bless you all real good, and we hope to see you again. God bless you.
Amen.
Amen.